Welcome to Ask Dr. Mingle. This video is part 2 of our frequently asked questions for the APM Performance Pathway. If you haven't seen the original episode, you can find a link to that video in the description below. Our first question for you today, Dr. Mingle, is how can we address identified gaps in care for paper practices in our ACO?
It makes great sense to me to use your quality analyses to improve your performance. And it needn't look much different at its highest level for paper versus electronic practices. We should be exchanging data at least quarterly and perhaps as often as monthly. You will provide to us the latest claims and clinical data, and we will process the quality performance analyses with the same logic we apply to the final annual report to Medicare. You will have access on our dashboard to a year-to-date quality performance score on each measure. On our dashboard, you will be able to drill through to scores by practice, scores by provider, performance for each patient on each measure. I suggest that you download a list of patients in the performance not met status for each measure for each practice. Remembering when I say performance not met, I'm in the background flipping the polarity of the inverse hemoglobin A1C measure, where higher scores are worse performance. So think of it in those terms. Now, someone in your ACO, or perhaps in each practice, and maybe it's preferable in each practice, should work those lists. There are a number of options, and you will want to choose what works best in your environment. You can have someone reach out to each of the patients with gaps and schedule things remotely, provide remote services, provide hemoglobin A1C testing or referral for a blood pressure check or medication adjustment. You can accelerate the next visit to address the gaps, or you can add a note to the chart or the schedule reminding the practice, reminding the provider to fill the gaps at the next visit. You can achieve best performance by using the analytics to inform your next encounter. Now, as we work together and as we get used to exchanging data, ultimately, I'd like to see this data become more and more real time and ultimately insert it into your EMRs for workflow enhancement. This data should ultimately be not only your feedback for reporting, but also your feed-forward decision support. But that's doing it perfectly now gets in the way of you doing a great job in submission to earn your shared savings. Thanks. Great question.
So another question we're seeing a lot, Dr. Mingle, is how do we get information like dispensed medications to meet exclusion criteria for certain measures?
Yeah, it's a great question. There's an enormous list of potential data sources from which to identify exceptions. Commonly, exceptions can be found in medication lists, in allergy lists, in problem lists, in results, in vital signs. Almost any data set in an EHR can contain data pertinent to exceptions. So as long as the data is machine readable and identifiable to the specific patient, you can provide us with structured data to identify the exceptions. Now, you don't have to find it all. There are two important processes that will go hand in hand as you plan your approach to exceptions. First, where and how far will you look? For each measure, what are the acceptable exceptions? How can we identify each exception? How accessible is the exception's data? And is it worth the effort? How much will your effort affect your scores? So you don't need to find it all. You need to set limits based on your perceived or measured cost benefit. Now, I've never seen Medicare audit or discipline a practice on what it did not find or even look for. If you claim performance is met or that an exception exists, you should be ready and able to send Medicare a copy of the data that says so. But I've never seen Medicare ask for proof that an intervention, an exception, or a measurement does not exist. So second, hand in hand with limiting where and how far you look, you should be working on standardizing your data collection and continually improve the documentation workflows or your efficiency at capturing and accessing that exception data. So year to year, it's easier to find exceptions data. You don't have to cast a broad net over most of the potential lists in your EHR.
So the next question we're seeing often, Dr. Mingle, is does the number of MPIs affect the quality reporting process?
Oh, yes, that's a great question. In one sense, no, it doesn't. Really, assessing and reporting quality on one provider is, for us, very much the same as the process of reporting for multiple providers. Whether there's 1 or 1,000 NPIs represented in the measure, the output is structurally the same. The denominator is the count of patients for whom the measure is indicated, whether the target audience is the provider's patients or the tax ID number's patients or the ACO's patients. Numerator is the count of patients for whom performance is met. We calculate and report exceptions, exclusions, reporting rate, and performance rate on top of the count of denominators and numerators. Now, on the other hand, more NPIs does make it a little more complicated. It gives a bigger number of patients, gives more variation in documentation practices. It relates to more complexity in the data collection, larger data sets we need to exchange, and a bigger job to appropriately identify and deduplicate the patient population. Now, there are 4 kinds of reporting that we are doing today. We report for individuals, that's 1 NPI at a time. We report for groups, that's 1 tax ID number at a time with all the TINs, all the NPIs that are billing in that TIN. We report NVPs. That's multiple groups of NPIs from each tax ID number. So a tax ID number doesn't become just its composite NPIs, but it's groups of NPIs grouped by MVP eligibility, essentially. And we're reporting for APP, which is multiple tax ID number practices with either some or all of their MPIs, depending on the model, from each ACO or advanced alternate payment models, APM. Now, each step up in that list, as you go from individual to group to MVP to APP, reflects a higher level of complexity in collecting data, analyzing the data, and displaying the data, and gradually increases the size of the data sets as well. So adds to the complexity. I think, though, that the largest driver of complexity in any quality reporting effort is the number of distinct information systems. The complexity we see in large number of tax ID numbers is driven primarily by the independent selection and maintenance of information systems. Even the same EHR implemented and maintained in separate instances significantly adds to complexity.
So the next common question that we see from ACOs, Dr. Mingle, it's often asked, do we at Mingle Health have difficulty obtaining data from smaller practices with limited technological capabilities?
Oh, another great question. Interesting. I'm going to have to answer that one with a definitive yes and no. Now, we've always taken all comers from our inception and from the start of Medicare reporting processes, from small practices with limited technological capabilities through large practices with abundant technical skills and resources. And we've developed workable processes for each variation on that theme. Now, I love the push-button simplicity of electronic quality measurement. Although it's never as easy and foolproof as we would like, it's never really push-button simple. It's more of a dream than a reality. There's commonly holes in the data leading to an underestimation of performance. Holes always underestimate performance. They never falsely increase performance. Problems include the lack of structured documentation, the lack of documentation standards, absent elements such as exceptions, data that's held in text instead of as structured data received as a fax or a PDF document in your system and not included in the structured data. Now, small or large, practices on paper or practices on an EHR without access or capability of extracting the data, all those times fall back on chart abstractions. Now, it can be hard to do, especially for the practice. Understanding which patient charts to pull will help with that. Each measure might require an enormous number of chart abstractions. Once abstracted and transmitted to us in a spreadsheet format, it's just as easy, if not easier for us, as it is to process electronically extracted data. It tends to be more accurate. Better performance is typically documented than the typically electronically extracted measures. So even though it is a lot of effort for the practice to generate these abstractions, it does show up as better scores generally in your submissions.
The next question, Dr. Mingle, is once an ACO starts the APP reporting process, how much time is required for member practice communication and education regarding the requirements for the APP?
We certainly see a lot of variation in how much training and support each ACO gives its practices. Adequate training and support pays off with better performance scores. To start with, a good hour with a knowledgeable resource should give an adequate understanding of the basics, although to generate accurate and great metrics requires a deeper knowledge that goes beyond the understanding of the specifications. Numerator denominator specs of each measure is a good starting point. Understanding the documentation workflows and variation in those workflows is important. Cataloging the location in your specific system of the data you need is required. The access rights and skill to locate the data and transmit what is wanted and needed is also important. There can be both business and security barriers to access the data, and there are factors controlled by entities outside of your practice, including the EHR vendor, the data host, and other intermediaries. Knowing who to ask and how to get access permission and credentials may be more difficult than acquiring the tools and skills to access it and extract it. I think you're in the right ballpark to devote an hour monthly to focus on training, education, and problem solving of your system. I like group processes where everyone meets at once. Everyone hears the same thing at the same time. Questions are asked that everybody needs to know, but only one person thought to ask. Important lessons are shared about how practices get access to their data. Often practices in a group in an region, though on separate instances of EHR, are using the same EHR. And as they find out who to ask to get access, they can share that with everyone else and learn and spread that advantage. You will develop your own shared support as your group gets to know each other and get comfortable asking for help and helping each other. You'll find that cross-fertilization to be quite effective. Um, and varies from practice to practice how much the ACO provides and how much Mingle Health provides. You can certainly ask us for more support. The best process is always one where the burden is shared. Where you have the local support that comes back to the expert for expert guidance and help. So that monthly hour is the time you're learning together, but then there'll be additional time that individuals use to do the work, and that again will vary with the complexity of the data you're extracting or abstracting, and the skills of those people doing it. And I won't hazard a guess of what that time commitment will be.
So our next question for you today, Dr. Mingle, is about CQMs and ECQMs. What is the difference between ECQMs and CQMs? And what is the level of manual abstraction required for each option?
Oh, great question. The first thing that leaps out of that question is the concept of manual abstraction. If you need to or want to do manual chart abstraction, you cannot do ECQMs. ECQMs are electronic only, no abstractions allowed. In fact, the electronic data for ECQMs can only come from certified EHR technology, that is CEHRT. If you want to report electronically from any secondary source like a diabetes registry or cardiovascular registry or laboratory information system, you can't do ECQMs. In fact, I think that there are commonly used systems that put your ECQM submission at risk. We commonly use practice management system data to generate denominators. And we commonly get data from reporting databases or clinical data repositories for numerator data. Now, if you're using those systems as part of your ECQM submission generation, your practice management system and or your data repository may not be certified and could put the validity of your submission at risk. It would not be the kind of thing that Medicare would notice unless it took a deep dive into your submission technique. So successful submission in the past may not be adequate assurance that you'll continue to be able to do it this way. Now, a little bit more on the differences. When you're referring to CQMs, you're thinking MIPS CQMs or Medicare CQMs. They work off the same specifications and dynamics as each other, except that the MIPS CQMs draws from all patients and all insurers of all providers' practices in the ACO. Medicare CQMs only includes Medicare Part B patients and only if they've seen a primary care provider in the primary or secondary list of primary care providers from any of the practices in the ACO. Now, ECQMs uses different specifications that is limited to standardized electronic clinical concept sets. ECQMs are all patients of all payers. ECQMs must be all electronic with no manual selection or manual editing of the data. If you need to edit data for an ECQM, you have to go back to the core data, change it there, that is the legal electronic record, and then rerun the analyses. Now, the three techniques are also benchmarked separately. ECQMs are benchmarked and scored only in comparison to other ECQM submissions of the same measures. Likewise, MIPS CQMs are measured and are benchmarked and scored against each other, and Medicare CQMs we expect to be scored and benchmarked against each other. ECQMs are exclusive. You have to be all electronic for an ECQM submission. You can't use any manually abstracted data or any manually edited data, and no electronic data from non-certified sources. In contrast, MIPS CQMs and Medicare CQMs can use any valid data from any source. They can edit and combine data sources without any risk of invalidation. These CQM submissions can be all electronic and only from certified EHR sources, just like ECQMs, but they can also be all electronic data from non-certified sources. They can be all manually abstracted data, and they can be any combination of those sources as long as you appropriately identify and deduplicate patients in those data sets.
Our next commonly asked question for you today, Dr. Mingle, is do providers need to know their quality performance level before engaging with Mingle Health?
That's an interesting question. I view it as an analogy to my years as a primary care physician. I never expected my patients to know what ailed them when they came to see me. Likewise, I see as our role with our clients to bring our clients to a point of knowing their clinical performance levels. It's specifically our role to help our clients come to measure, report, and improve their quality performance levels. So no, you don't need to know what your level is before engaging with us. Although if you do, it can get you at a higher level of development and a higher evolutionary state when you start.
And our next question is about MIPS before joining an ACO or in gap years between iterations of an ACO. The question is, how do we incentivize our providers to participate in MIPS before they join our ACO or in those gap years?
Oh, great question, and a great idea I see underlying it. The three measures of the APP are standard MIPS measures in broad use. Practices who have been using those measures for MIPS before engaging in the ACO will be an advantage, both process-wise, efficiency, and expectations of score. Now, sharing the cost of MIPS reporting for those practices in a gap year or who are in the year or years leading up to a practice joining the ACO may be a great tool. Practices can include the three APP measures in their set of six MIPS measures, or they can submit them as three extra measures if they are more confident of better MIPS adjustment scores using other measures. But as long as they're measuring them in one fashion or other, they will be doing work that's important to their future work with the APP, and they'll be laying a foundation that helps them more rapidly improve their performance. Not only do your practices get valuable experience, but you can go into the relationship with a foreknowledge of what you can expect a new practice to do to your scores. I'm inclined also to think that performance should be reflected in practice revenues somehow. This may be the best way to incent pre ACO learning uh, and performance improvement. The ACO optimally will be earning shared savings. Some of those shared savings will be used to build and or maintain infrastructure. Some will be distributed to the participants. That distribution should be favorably weighted. It doesn't have to be proportionate, but there should be some additional weight applied to those practices doing that are contributing better performance metrics to the um, overall submission. If you come into the relationship with a history of performance scores previously generated, you can incent a new practice with first year terms reflecting their historical performance. The work done by your new practices engaged with Mingle before joining the ACO, or in that gap year between ACO iterations, will perfectly translate into data that can be blended into the ACO submission. Essentially, all of the infrastructure, knowledge, and skills gained in the MIPS effort before or in gap years of the ACO will be reusable for the ACO APP efforts.
Next up for you today, Dr. Mingle, is how can Mingle Health add value compared to EMR-based reporting solutions?
Great question. I think it can be summed up by saying Mingle gives you flexibility, the value of which will become obvious to you as you try to meet the quality standard to affect full collection of your shared savings. You'll encounter many challenges in your measurement process and should typically more easily find solutions with Mingle and using the MIPS or Medicare CQM processes instead of the eCQM processes. Part of the advantage is the EHR compared to the third party approach to data. Most ACOs have multiple tax ID number practices representing multiple distinct EHR and practice management systems. Now, EHRs do not play well together. I find that most say, of course, we can handle your overall system needs. All you have to do is import data from all the other practice EHRs and translate it to our data model. Now, they leave you with a monumental task with too little support and a ready excuse for their underperformance. When I say monumental, think monumental effort, monumental expense to build and maintain an infrastructure that works. An expense that grows every time you add a new practice or a practice that changes EHR. Now, the other part of the Mingle advantage relates to the difference between eCQM and registry requirements and processes. eCQMs are exclusive. You have to use certified EHR technology, beginning to end. You have to have the documentation templates precisely built. Your providers have to use the prescribed documentation workflows. You cannot manually manipulate the data in any way. You cannot fill any holes with data collected in any way from any other source. And ECUMs commonly fail as they try to blend data from multiple EHRs or even multiple instances of the same EHR. MIPS and Medicare CQMs, in contrast, are flexible and inclusive. You can be all electronic, just like eCQMs. You can exclusively use certified EHR technology, just like eCQMs. But you can include data from any source collected in any way. Data simply has to be accurate to be valid in a MIPS or Medicare CQM submission. Certification is not required. Electronic workflows are not required. You can solve your problems in any fashion that works, which is a big advantage when you're competing with all other ACOs to hit the quality standard and collect your shared savings.
So the final question for you today, Dr. Mingle, is April too late to start engaging with Mingle Health for APP reporting in 2024?
Great question. And I'm going to have to say it's never too late to get started. You have to start sometime, and the sooner the better. If you miss April, there's no better time than May to get started. If you miss May, now I can keep going, but you get the point. The later the start, the lower you'll need to adjust your expectations. With 3 months, we can technically effectively build a submission for you. That means a December 31st engagement is likely to result in a submission by March 31st. But there's a lot more you need to do than just a technically effective submission. To get great scoring is not just a year-long process, but a years-long or continuous process. Now, the other factor you'll be dealing with is that between now and March 31st of 2026, all ACOs will have to submit their APP quality data as MIPS CQMs, Medicare CQMs, or eCQMs. Web interface will be out. An entire market is in flux, and about 1/3 of all Medicare providers will be competing for engagements with vendors who are all working to increase their capacity. If you wait too long, you may not get an effective seat at a table. So the sooner the better. The longer you wait, the less likely you are even to get the technical submission right. And certainly the longer you work on it, the better your scores are going to be.